Good afternoon, everybody. My name is ccraigmile. I'm a certified safe patient handling professional. I'm with Mark Van Leuven. I was a physical therapist and a certified safe patient handling clinician. Today, we're going to be looking at five different techniques using 4 different devices on proning our ICU and ARDS patients. We're also going to touch a little bit on safe patient handling during this unique time in the pandemic with the COVID-19. And then we're going to touch quickly on a couple other minor topics. I really want to thank Sasha Latvala, Ashley Thomas, and Donna Brennan. They helped us with this video initially, but due to some technical difficulties on our part, we're re-recording this to clean it up so you can better hear the audio and the techniques. For full disclosure, a couple things. First and foremost, the techniques we're using are not the primary design of the equipment that we're using and may not be user recommended by the manufacturer. We're taking what we have and using it to the best of our ability to complete the task of proning those patients. Please always, always, always follow your facility's policy on both safe patient handling and on usage of equipment before ever attempting proning patients with the techniques we're about to show you, and make sure you trial this and practice this prior to using it on a patient. What we're going to be looking at, the 4 pieces, we're going to be doing an air transfer device, repositioning sheets, and a ceiling lift or a floor lift. We will show you that using a ceiling lift is much more effective, but we do not have one. Using slide sheets and doing a cocoon method, and then just doing a full manual turn using just your flat sheets and draw sheets. I found this online, and I found it to be really a great plan of action, if you will. It's called the 5 Ps. Prepare, get everything ready on your patient, being disconnect your ECGs, plan. Everybody knows their role, so whether they're going to be turning the patient, who's going to be at the head managing the airway, the perform, doing the actual proning, the ready, set, go, and all the different steps that go with it. Protect, check the pressure points, make sure you have the pose in the right place, rotate the head, and then perfect. Double check everything, your tubes, your catheter, arms location, the swimmer's position, pillows, so on and so forth. This was taken off a great website, the link's below. I would highly recommend adapting something like this for your practices and your policy. So what we're going to do now is do a proning using a second surface on an air transfer device. This is Mark Van Leuven.
Before you continue, I just want to touch a little bit more on line preparation in the ICU. At the head of the bed, off to one side, you're obviously going to have your ventilator here. Okay, we all know ventilator tubing is only so long. So when we go through this technique, the headboard would need to be off so that we make sure we can slide the vent as we laterally transfer the patient for proning, that we can slide the vent along with patient to make sure that the line goes along. Make sure you consult with your respiratory therapist. Probably have them there to help manage that line so there's enough slack when you go to prone the patient. Okay. You also want to make sure that you check whether it's a TLC or whatever peripheral lines you have. Check with the nursing staff as to what can and cannot be disconnected, and you make sure you position those at the head or the foot of the bed so that they don't get wrapped up in the patient as you're proning them.
Excellent. So what we're going to do first is by using an air transfer device. Patient's already on it. One of the neatest tricks we do is by using this is an OR trick, using a pillowcase. Oftentimes we're going to be sliding him off. That surface is our stretcher. This is the bed they're on. We're going to lay him flat, transfer him over onto that surface, get this surface prepped with another HoverMatt or another air transfer device and pillows, and then prone him off of that surface onto this surface. What this does, by tucking the pillowcase underneath his body, just a couple of inches, laying the arm and all the tubing in place, and then retucking this under his body. It physically locks that arm in place, so the person on this side, what will happen is that arm will flop under and land under the patient. So usually somebody has to physically hold that and then have the patient land on their arms. In this scenario, this will lock everything in place, so when he does prone onto this surface, we don't have any issues with the arm getting stuck, and we don't have any issues with the tubing pulling out.
Just to review that again, it's under the patient, under the arm, around the arm, and then back under the patient.
So literally we'll take that arm and literally attach it right next to the body. So we're going to start by doing a lateral transfer with our air transfer device. We're going to always have somebody holding onto the HoverMatt on that side. Wonderful. Going from a slightly higher to a slightly lower position. Ironically, we've always said, make sure you always go feet first and then head first whenever we're doing a lateral transfer. Now I'm going to show you why. If we were to go straight across and you have too much height, is actually the proning technique we're going to use. So first, he's going to grab a hold of the mat and he's going to say, Chris, turn it on.
Chris, turn it on.
Now we're going to use the adjustable button on the air canister to make sure our patient is centered on the HoverMatt itself. We can slowly inflate it. He's centered. Perfect. Now at this time, we're going to be prepping our bed. We're going to be double checking our patient. This will normally only take a few seconds to do. We're going to raise this bed surface all the way to the top. And we're going to lower the neck surface down. Prior to that, we're going to place our flat sheet, a HoverMatt, and pillows. Depending on where you need the pillows lined up based on your patient, where did that happen? Like this. Now, if you are using a head pillow or a foam enclosed pillow at the top of the head, where that mat is going to actually be in the way, you can actually slide the entire air transfer device down so the top of it's right at the shoulders here, so then you can place the head piece of this, or if you need to move it and you're attaching off the head of the bed. Also note, in both these scenarios, if anytime you're doing proning, make sure your headboard is removed so you can have full access to that patient. In this case, we're going to just be using a standard 3-pillow setup. We're going to lower that surface down about 3 to 4 inches lower than you would normally go. Because what we're looking at is we're going to prone this patient onto the top of those pillows. The bigger your patient, the faster that patient will turn. Be very aware of that. In this case, our patient is relatively light, so they're not going to turn very fast at all. The heavier patient, this is ideal when you have that larger patient with a large thigh mass or a large abdomen. This makes it so much easier to prone that patient. So we're going to line them up here, where the tuck is under. I'm going to hold onto the mat.
And understand also, these beds would be higher. We're obviously tall. These beds would be higher. They're a little older, so they're not going up as high as a normal hospital bed.
Go ahead and turn it on for us.
Ready, Chris?
We're going to do the task first and then explain what we're doing. So again, what we're going to do now is show you what that looks like with somebody who's actually on it. The patient in weight. But that patient's weight, when you get to the edge of this surface, will automatically, by pushing down on the mat, prone them directly into the space. The larger your patient, the faster and easier they're going to turn. So my rule of thumb has always been one person to do the airway, and then at minimum, always 2 people to do the transfer course. At 2 to 200 pounds, 2 people. 200 to 300 pounds, 3 people, 300 to 400 pounds, 4 people, 400 to 500 pounds, 5 people, and so on.
And realistically, you're going to have more people in your ICU room to manage this. Likely anesthesiology or respiratory to manage the vent, and then you're going to have, 2 nurses, 2 aides, a PT, 2 PTs, whatever it might be. You're going to have the manpower to do that, to manage all the things that need to be managed.
So from here, we can now boost or turn him slightly using the HoverMatt. You then can apply this. His arm's not going to go.
His arm doesn't articulate that way, but.
And do the swim position. You can control the airway both. If you need to move him up or you need to inflate this to get access to things, you can still do that by inflating the HoverMatt and tucking the pillows underneath.
The pillows are right at the chest, the pelvis, and then below the knee to make sure that we get the heels and toes up off the bed.
Now these air transfer devices actually have on them, they're called links. So these anchor physically to the mattress, or to the bed frame itself. When we anchor that, we want to make sure we anchor that to the physical frame next to the mattress. Every frame I've seen has that, because after we get them in this position, we're then going to try to do a steep reverse trend. When we do that reverse trend, we don't want that moving. So by having the link system, that locks the HoverMatt, which in turn will lock the patient directly onto the surface. This one also has Velcro straps. You can actually go across and help hold that patient in place real time, if necessary. What we're going to do now is go through the return process, which is getting him back supine onto our next surface and then back in the bed again. Make sure you disconnect the headboard or the link system from the mattress.
And realize that when we proned this guy, the first time the reason we went back is because we didn't slide him laterally enough to get him to the middle of the bed.
So we're going to go through the same process again. We're going to inflate the mat. We're going to bring him across to where his body is going to start to tilt.
And we would have this dressed with the sheet and chuck pad as well.
And when you're ready?
Ready?
When I'm on this side, what I try to make sure is that shoulder is ending up right square on this part of the mat. So he ends up centered then on this surface. What we're going to show you quickly is what this looks like with a real person. So even though there's 2 of us, Mark is going to prone me back on to leave the pillows or not. He's going to prone me right back onto this surface, and we're going to have Drew here slide off.
Non-safe patient handling.
Yeah. But I think it's important for you to see how easy and how fast these people can move when it's somebody who actually has weight to them.
So we're showing you something that doesn't involve enough people, just so you know.
You would have, for somebody of my size and my weight, you'd have somebody on this side, you would then have somebody on that side, and somebody controlling the airway.
And at least 3 people, and then somebody else would be managing the button. So I always have a person holding on, and because we're slippery, even though you don't mind if he slips on the pillowcase. You're gonna tuck your arm.
I'll tuck my arm.
Consider the pillowcase, it would be on his inside right arm here if we were to tuck that, but since he's able-bodied, he can tuck his own. The air device does have this air device has an adjustable button. You can hit it up to 4 times. Not every air device has that. If you don't have one, obviously you're just gonna turn it on. We're gonna hit the one that gives us the most air pressure. So you can see how quickly that happens, and obviously there will be people here to collect.
Absolutely, Christopher. So as we're doing this, trying to get that patient, especially larger patients, prone into that same space, is highly, highly, highly recommended usage of a second service. So let's say we don't have enough space in our ICU, or we're using a med-surg room, or any number of different factors. We're now going to show you how you can pronate patient on a single surface using a HoverMatt or using an air transfer device. What we found the best and safest way possible. So we're going to get our friend again. Hello. All right, George. George, I need you to be comatose again. You're doing such a great job of that. And our pillowcase is there. Thank you, sir. We're still going to use the pillowcase technique. You're going to have this up at a good level to hold that patient in place. If your patient has probably a better place to put it. If your patient is taking up more than 3/4 of the bed, you're going to have an extraordinarily difficult time proning them on the same surface. Just because of their width and oftentimes their girth, you're not going to be able to do that. So the first thing we're going to do in this scenario is get everything ready. So we've got a second HoverMatt, we've got our pillows and our draw sheet. We're then going to bring this up to the highest position possible, make sure we disconnect the link system from the HoverMatt or from the mattress. We're going to hook our HoverMatt or air mattress up, air transfer device, and we're going to apply a HoverMatt right under the same place, because as we prone him, we're going to be removing the top HoverMatt that he's on and be putting a new HoverMatt underneath so we can then supine him back when we're all set. So the first thing we do is I'm going to ask Mark to hold on to the mat. Excellent. This takes a minimum of 4 caregivers, 2 to hold the mat itself and 2 to apply the new mat. We're going to show you how that works. So we're going to take this mat, inflate it, start at the head and slide the new mat directly in that cushion of air between the 2 surfaces. So he's going to be at the head there. He's going to say, Chris, turn it on. So what we did is 2 people would be holding that top mat, 2 people would be sliding that old mat in place. We're then going to connect that mat directly to the frame of the bed, both at the head and the feet, and that's going to lock that mat in place when we go to remove the top mat and then to prone the patient.
Now, if you do not have a link, then you would obviously want somebody to be able to hold that so it doesn't slide.
So what we're doing now is getting our pillows lined up. So when we go to turn him, which way are we going to turn him?
Toward me.
Toward you. Actually, we're going to turn him towards me, because I already put the arm.
Okay.
So we're going to put the handrail up on that side.
The challenge is the pillows, okay? When you flip somebody over, if you don't tuck the pillows just right, then they're going to end up kind of shooting out the other side. So what you're going to see is we're going to come toward me first with a lateral. I'm going to keep my leg, even though I'm using the railing, I'm still going to keep my other leg here just so I know where the edge is. And I'm going to slide the mat up the railing, up my body a little bit. We're going to leave it inflated so that Chris can then tuck these pillows underneath George so that when we prone him, they're still underneath him, okay? It sounds long like what we're talking about, and we're doing it to demonstrate it, so it'll take a little longer, but when you're doing it real time, and you have more people, it's slide, up, tuck, 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 prone, okay?
Are you ready? So we did everything. We've done our plan, we've done our prep. Now we're going to do the process. So if we look at the positioning of our patient, his arm stayed right in place, and he is centered on all three pillows. Then to supine him out again, first and foremost, again, this is a normal sized person, you know, not somebody with a large abdomen or a large spine mass. Just because if you think about it, if we get him all the way to the side and he's up, and that patient takes up more than half this surface, you are never going to be able to prone him and center him on the toes. That's when that second surface is really needed.
Yeah.
So if your patient is not of size, this is the best and safest way to do that. We can now supine him.
And that second service doesn't have to be another bed. It most likely will be a stretcher. And realize too that throughout all of this, there's somebody managing his head and his hair and his airway. He doesn't have hair. His airway. Good. Yeah.
All right. So which way do you want to go?
Back towards you.
Perfect.
Go.
Oh, no, no.
Toward me. Go on. So the arm that gets tucked is always the one that is going to be rolled on. So we're going to repeat the process. So we're going to unhook this, which stayed in place nicely. And then we're going to put the HoverMatt back underneath him and reattach it. And then we'll bring him back to supine.
Now you may think this is going to take longer than just manually grabbing him and going. It may take a minute or two longer, but it's significantly safer for your patient and significantly safer for your staff. The amount of force and stress it takes to do this is minimal, especially if I'm using that second surface.
Again, as we do this, someone will be managing the person's airway here.
So right now, we're going to reapply that HoverMatt underneath the surface.
Now, we didn't do that as well as we could because we didn't do it together. So we kind of pulled differently, but because the air was inflated, we had time for him to catch up because I got a little overzealous.
So we're now going to anchor the mat back in place.
my direction?
Yep. And we would go top sheet and chuck so that he's got something underneath him. We only have one chuck, so we just put the top sheet. So we're coming toward me again.
We're going to come towards you. 1 slide, 2 up, 3 over. Perfect. You ready, sir?
Ready?
Hot mat.
Up now. Obviously, as I'm the one that has to turn that off, you could see the back going a little crazy. Once I would hold that there would be somebody to turn that off. One thing to note, we came laterally, we came up, and then we came over. The last little piece to make sure the patients get centered was as I pulled it out, Chris gave another little push back laterally toward me to get the patient centered. So it's not just lateral up and over, lateral up, over, and then a little slide this way as you position the patient, okay?
Anything else you need to cover with the air transfer device?
I think we got it.
Excellent.
Take your time, make sure you plan ahead.
So our second opportunity, or our second tool we're going to look at for proning is using a lift system and repositioning sheets. So as you'll see, the best thing to have for this scenario is a ceiling lift system because of the height. Because this is as low as the bed go, we have a scale, and that's as high as this goes. You'll find that you can't get enough height to get that patient completely prone and turned over. Again, so we're going from what we consider the best to the better. This is going to be better than other options. And then we're going to look at the rest. So first thing we're going to do is we've got our patient who's on a repositioning sheet. We're going to bring the system in. We're going to apply our repositioning sheet. No, we're going to leave the head on for this, the head off for
Make sure that you're on the same point of attachment for each strap.
Now this is an older repositioning sheet. So what you're going to see is it only has one set. Most everybody else has two. So we're going to now use our ceiling lift system or our floor-based lift and lift that patient up and apply a second repositioning sheet underneath that patient.
But again, there would be other people here to help manage the patient's head and airway. We elevated the head a little bit just for positioning purposes as the patient gets lifted up. When I start to initiate the lift, I'm going to let tension get on these straps, and I'm just going to make sure I check each one to make sure that they're not slid out of place. Obviously, we would have more people so our patient wouldn't be dangling like a sack of potato.
The second thing we're going to do is between the two surfaces is apply a slide sheet about 3/4 of the way underneath. And the reason is when we go to turn that patient, that's going to keep that bottom repositioning sheet in place.
Perfect. It also makes it easier to get that last little bit of proning.
So as you guys also can tell, we have this at the lowest level. The reason we've got this at the lowest level is because of the height of our floor lift. We want to make sure we get enough height to be able to turn that patient all the way to the prone position. So as he's unclipping, we're going to get our pillows and
Just so you can see how I'm getting this out, I'm going over the top, through the loop, and then it just slides through.
We're going to put the handrail up on that side. We're going to bring our lift in. Now we're just connecting that side. So as with the air transfer device, if your patient is taking up this entire surface, you're going to have a very hard time proning him in this scenario. Now, if you also notice, we did not connect the head. As we go, somebody's going to be managing and controlling that airway here. So what we're going to do is slowly lift and slowly slide that patient across. The lift's going to be doing your ceiling lift or floor lift is going to be doing all the turning. And we're going to slide into position. We're going to have our pillows ready.
And hopefully you have an XY track so that you can freely move that lift as you need to, as you're lifting.
Ready?
Ready?
Start to lift.
So again, I'm just gonna, as I'm lifting, I'm making sure I've got good tension here. Brakes are off on the lift so it can adjust itself. I'm not exerting force. The slide sheet did that for me, just so you know. Now we're going to stop here so that we don't get the patient prone too early. Chris is going to tuck those underneath the sheet.
Actually, I'm going to go under
the slide sheet, yep. And there will be another person to help hold things in place. Obviously, there's just two of us here at the moment. So take this with a grain of salt with respect to that portion of it.
That's the rest way over.
So we've got the patient underneath. I'm going to slide this out nice and easy against the slide sheet. And Chris was able to position the pillows nice and easy using the slide sheet. Now to take this slide sheet out, Chris is just going to tuck that portion underneath.
And what's great is by having the pillows there, you have gaps where you can just slide your hand and remove that right underneath the bottom.
Now I'm not going to slide the top portion. I'm going to take the bottom portion of this and just pull on itself. And it's just going to come right out, sliding against the top portion, nice and easy. You can see the patient didn't even move. It's not the tablecloth trick. I'm not standing and yanking. It's just a nice, easy pull.
And to that point, if you notice, by having that slide sheet between the two surfaces, that bottom sheet did not move at all. What we found is by not having that slide sheet, when we go to prone the patient, the repositioning sheet on the bottom gets pulled all the way out that side and is not centered at all. So it's a great way to make sure that that stays in place. Your pillows can get lined up, and then you can position the patient easily over the top, remove the pillows, check your lines, and go through those 5 Ps that we plan, procedure, perfect. Excellent. Excellent. So the next thing we're going to be doing is supining him back. You're going to bring the lift in. We're going to slightly lift him off the surface and reapply the repositioning sheet, because after we supine him, we all know we're probably going to have to prone him in the next hour or two. You didn't feel yourself getting prone the last time? A little lower? Perfect.
Good. We're not going to attach the head so that we don't hyperextend the patient's neck.
So do you know what we ended up doing last time? I apologize. We actually put a slide sheet and placed that under using a slide sheet as we turn. Okay. So we're going to show you another way to do this. And I remember the reasoning for this now. What we found is, so if we tried to lift him in the prone position and use that repositioning sheet, it really fluxes the back and gets everything out of alignment.
And their neck.
And their neck. So what we're going to do is hook this up as we were going to do that.
I thought I was crazy.
No, yeah. As you can see, we work together way too much. So I'm going to just apply this by tucking it directly under these two surfaces, just like I would be doing a normal tubular slide sheet. Make sure I'm covering the large portion, which is from the hip to the head. If you notice, I have a piece hanging out here. I'm going to take my second repositioning sheet. I'm going to start it by putting it underneath that patient. Right under the tubular slide sheet. So as I turn, I can then be taking this repositioning sheet with it. So he prones out center on my neck surface. So I'm here, I'm going to be controlling body. You're going to may not want to do head. The reason we don't want to do that head is because we don't want that pulling at that trach or that airway at all. There'll be somebody there to manage that. Thank you.
Thank you. So if this were a ceiling lift, we would have this positioned in a different spot. Again, the lift is doing this work, not me. Once we get them where we need to, there. I'm going to give a little push, and a little pull at the end with the slide sheet. So now that's where it needs to be.
And he is then ready to go on your second surface, on your repositioning sheet, so you can start the process over again. Check for your tubing and everything else as through the process.
It's certainly a little tedious, but it is very safe as far as the amount of effort you have to exert. This makes it a lot easier to be able to get the patient in the right position. Without the combination of this and the slide sheet, there's a lot more tugging and pulling of pillows and of the patient to get them in the position that you want them in.
There's a lot of shearing that can go on for sure. Anything else?
No.
One more. So as we had stated, this is a good, better, best approach. So we don't have air transfer devices available. We don't have ceiling lifts available. Your next best option is going to be using slide sheets to prone that patient. So it's going to be a similar technique. The setup is significantly different. So our patient, we're going to clean the tubes, EKGs and everything off our patient. We're going to get our pillows preset. We're going to take a second, and again, if they have a large abdomen, you need more pillows at the chest or the legs, you can do all of that at this point. You're going to take a second flat sheet. The patient is on a flat sheet. You're going to use a second flat sheet. You're going to pull it up and then fold it over. So you're going to have about 12 to 14 inches. So the head and airway are open here. We're going to then take these sheets themselves, and you're going to roll them up like you're making it, like you're rolling a taco. You're going to roll that, and you're going to roll that as tight as you can.
Or a burrito. Tacos are open-ended.
Or a burrito. You're going to roll that as tight as you can. So as we're looking at the number of people it takes to do each task, when you're using an air transfer device, the amount of effort is minimal. When we're doing the ceiling lift or floor lift systems, it's a little more effort. There's a lot more going on. When you're doing this, at minimum, you're going to have 3 people on either side plus 1 controlling the airway. Minimum 3 people on each side. So you're going to have 1 controlling the feet, 1 controlling the hips, 1 controlling the shoulder, 1 controlling the head. So there's 2 separate ways we can apply slide sheets. So we're going to use slide sheets to do this task. The first way, these are tubular slide sheets. You're going to tuck it under so you have half on my side, half on his side.
And we're going underneath the bottom sheet.
You're going underneath the whole thing. And you're just going to tuck to make sure you're covering from the hip to the shoulder all the way across. Which way are we going to turn?
So we're just showing that.
Oh, I'm sorry. You're right.
So the reason that we use 2 is so that when we complete the task, we're going to go toward Chris. So we were going to slide up and then over, okay? So we use the slide sheet to get me over, This one will roll that way as we use most of that one to get over toward Chris, and then we're using this one to get the patient over and finish the prone. Problem without the slide sheet is that it's hard to finish the prone. You start getting them on their side, and then it's the slide sheet that helps get them more that way to get them all the way prone. That's why we use two, okay? Or if you have a big enough one, okay, this is a bariatric one, so it's going to be on each side, okay? But what I'm going to do is we're going to get this underneath the patient without rolling them. I'm going to hold this. Obviously, I'm 6'3", so it's a little easier for me, but if you needed to, you could use the patient as a table, which we're not supposed to do, but if you had to, okay? So just so you can see it, I'm going to fold this away from myself and then toward myself. And I'm going to continue away, toward, away, toward, away, toward, away, until it's just one giant accordion. It doesn't have to be perfect. The first time I ever did this, I screwed it up like 3 times. Now it's just second nature. We're going to pass this underneath the lumbar spine where there's a natural curve. So I'm literally just taking this, shoving it under to Chris, who grabs the end, okay? We're going to take this end together. We're going to slide it up. We're going to take the other end and slide it down. Okay, now, there would be a fitted sheet on the mattress. We don't have that currently, but there would be one there. So we've got enough slide sheet on either side because of the width of the bariatric slide sheet. We're going to re-burrito.
I'm going to put the handrail up on my side. You're going to see why. Because when I come across, I'm going to use that handrail as a guide to have the patient come right up on the side.
Now when I'm doing this, because it's just me, I'm at shoulder blade and pelvis, so I'm getting most of the trunk.
And again, you would be having no less than 7 people, 6 people on either, 3 people on either side, and then 1 managing the airway. On 3, we're going to go over, then up, then from. Okay. On 3 over, 1, 2, 3. 1, 2, 3 up.
And 1, 2, 3 over. So that last little push I got, use the slide sheet to get the patient prone, okay? If we take this sheet off now, George is a little exposed. Poor George. You can, we've got him on the pillows pretty well, and then we can position him from there.
Now, after you get into here, you saw that fold that we did here, the 14 inches. So what I can do now is grab that, and just gently pull, and then we are covering the entire surface. So to supine him, we're going to do the exact same thing, except backwards. We're going to take our flat sheet.
Now, if you notice, we did not use the pillowcase technique on this because the patient's hands are tucked up and held against the body with the burrito, with the sheets being folded up. Yeah. Make it harder than it needs to be. Why don't we do both just so we can show them both? So we're going to not use the bariatric one. We're going to use the 2 smaller ones tucked on each side. Again, this is just tucking underneath. So you're not rolling like you're changing linen. You're literally just taking it and tucking it underneath. That's all you have to do. Tuck, 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 tuck. Patient, somebody is managing the head.
We're going to come my way, up and over. And when you're ready. When you do this, we should mention this, you want this rolled up very, very tight and very, very close to the body. So if you notice, you want this so you're physically getting that entire body locked in place using that rolling technique. On 3 over, 1, 2, 3 over, 1, 2, 3 up, 1, 2, 3 down.
And again, that last little push underneath, it's just a quick push using the slide sheet, and then I'm able to get my hands out of the way. And now we got George back where he needs to be.
We can leave this here. The last technique is doing something very similar to that, except we're going to eliminate the use of the slide sheets. Now, I will tell you, having done this previously now a number of times with a full person, i.e. Mark, the amount of force it takes to physically prone a patient is substantial. This, and I'm sure a lot of you guys, a lot of people are doing this technique just because they don't have another option. So we're showing it. But when it comes to safety for your caregivers and safety for your patients, this is the last resort.
Slide sheets are very inexpensive.
Yes.
Especially disposable ones.
So same thing, we're going to put those pillows in place. We're going to burrito the patient. So if I have a patient of size, I'm going to want at least 8 or 9 people. You're going to want 4 people on either side plus 1 managing the airway.
Rail?
There's not enough space when you have.
There'll be more people, so no rail this time.
Exactly.
Okay, so less mechanical advantage. Same technique, more effort from you. In this case, make sure the bed is raised up appropriately so that everybody's about waist height, and you've got to get your butt down. Move through your base of support.
Okay, coming my way. On 3, 1, 2, 3, over. 1, 2, 3, up. And when you get to here, what works is if this person, you're going to grab 1 up top. You're going to have to grab 1 at the bottom because you're going to have to pull and turn at the same time.
So I'm giving a little push. Chris is giving a little pull down low. I'm pulling toward, and he's pushing up top.
Especially if you have a larger patient with a large abdomen or thigh mass, the amount of force it takes to get that patient centered supine is substantial. On 3, 1, 2, 3, prone. Now, what you'll see in other videos is oftentimes they then need to grab that patient and everybody get around them. Go ahead and grab that side for me. And they go 1, 2, 3, lift, and they center and slide the patient up. Again, in our world, that is the absolute worst thing we can do both for our caregiver and our patient. Good, better, best approach. This is better than trying to manually turn them without anything and just trying to manually turn them in place. This is a lot safer for your patient and your caregiver. At least it gives you something. It is the last resort. First resort is an air transfer device. Second is a ceiling lift repositioning sheets. Third is your slide sheets. Fourth is using this technique. Anything else on proning repositioning when it comes to this? Oh, we got to bring it back.
When you're using this, one of the most important things is 1 voice, 1 command, so that everybody's pulling in the same direction at the same time.
To that point, we forgot this at the beginning. That person who's, we've always had using air transfer devices, using repositioning slings, the person closest to the patient is the one in charge. Whenever we're proning a patient or the patient is intubated, the person controlling the airway is in charge of every turn and task that you do. So that person that's controlling the area, where I was standing there doing 1, 2, 3, they're the ones going, okay, does everybody understand what we're doing? Here's the plan. Okay, here's the process. We're going to fill it, check everything's clear, protect the patient. So this person's going to be calling the commands 1, 2, 3, slide, 1, 2, 3, up, 1, 2, 3, turn. Same thing goes all the way through the process because they're double checking your ET tubes, the airway, and everything else.
And watch the wires that you don't trip over them.
It's almost like being in a real room. All right, well, it's going to come my way. On 3, 1, 2, 3, over. 1, 2, 3, up. 1, 2, 3, turn.
Poor George. And the segmentation of that allows you to maintain control, which is what you want. So instead of one massively quick motion, it's done in segments so that you maintain control for the safety of the patient and the safety of your caregivers.
So those were the 4 pieces of equipment, well, 3 pieces of equipment, and then the manual movement of proning patients. I found this on the Canadian website, which was a great piece on everything we've got to look to after we prone our patient. So we want to make sure we're repositioning the head every Q2. We also want to make sure those arms are going into the swimmer's position to keep those shoulders from locking up. always looking at the assessment of the pressure for the vascular devices and tubes. Make sure the patient's not lying on the ECG and EEG tubes or electrodes. You can zip through this. The big thing is making sure there are no pressure points underneath that patient when they're prone. And each one of these has a little different option. That crawl position is huge. When you're using an air transfer device, if you have to move that patient up because of their mass, you can actually inflate that, which makes it a lot easier to turn that patient. The other thing is just make sure whether you're using a repositioning sheet or a slide sheet, that the surface is anchored as much as possible prior to doing the reverse Trendelenburg. One thing we did not mention, when you're using an air transfer device, depending on the style and type, if your patient is greater than 350 to 400 pounds, you can use 2 air canisters, one in either side, which will double the PSI inside the mat, significantly reducing the coefficient of force, making it a lot easier to move that patient. We find when we're dealing with patients that are of size, or larger patients, we really want to go out of our way to make sure that the 2 pumps are being used. A couple other things we need to look at. The infection prevention, we're going to quickly talk about the morgue, and we're going to be doing the Q&A for this. Infection prevention protocols. Terminally cleaning rooms is happening at most facilities, whether you're using the BioQuil, UV lighting, hydrogen peroxide, whatever the case may be. Do that to your safe patient handling equipment and or your safe patient handling rooms. That includes your air transfer devices, your slings, but most importantly, your lifts. They never get cleaned to the extent that they need to be, especially in this day and age. We want to eliminate any opportunity for cross-contamination. So I am unaware at this point of any company where that has a negative impact on the piece of equipment. I know the companies we represent, and most every other company I've ever worked with, it is fine to put them into one of those terminally cleaning rooms to kill everything that's on them. This should be done at this point weekly or as much as possible. Also, your ceiling lifts. When you're in a room, especially our ICU rooms, and we're cleaning those between patients, make sure they're pulling that ceiling, the strap all the way out and cleaning the entire length of the strap and then putting it back in. The reason is if we have any issues with cross-contamination, when you go to use that ceiling lift, if anything is on that strap, when you unwind it, that will fall directly into the patient's space. Reusable versus disposable versus wipeable. In long-term care and in some acute care facilities, we are using the same sling on multiple patients. Luckily, and at this point, slings are so inexpensive that if you don't have slings that are reusable and patient-specific, consider it now. Taking a sling from room to room is the simplest and easiest way to cross-contaminate space. Sit-to-stand slings are notorious for this. There are fully wipeable, non-porous sit-to-stand slings on the market. If you do not have a fully wipeable sit-to-stand sling, that means it should be laundered between each patient. Consider purchasing either 100% wipeable and or slings specific by patient. Gate belts, I don't think we're gating many of those folks right now, but gate belts are notoriously used person after person after person. Again, another extremely inexpensive tool that can be either disposable, single patient use, or patient specific. Single patient use or disposable products. When after a patient is discharged, that should immediately go in the trash. The fact that we used to be giving these products, including the boots, including air transfer devices, including slings, and letting patients take them home with them, do not allow that to happen anymore because the contamination level at home goes up significantly. Mobile lifts, make sure they're wiped down per manufacturer's directions. I am unaware of any
manufacturer, especially on your sit-to-stands, powered and non-powered, and your full patient lifts. Any sit-to-stand or any company that does not allow bleachable wipes for their equipment. That being said, the foot plates, the casters, the foot plates on sit-to-stands are notoriously dirty. Should all be used with bleach wipes, and the wheels, because you are rolling those across those floors. The calf straps also should be completely wiped down with a bleach wipe if we're in a COVID or precautionary room. Amber Perez did a great webinar on safe patient handling emergency preparedness that is directly in line with the present situation we're having. I'd highly recommend going and watching that. She covers a lot of that about the infection prevention stuff and the protocols as it relates to the rest of your safe patient handling program. Now, on a slightly darker note, and we're already seeing this in New York City, as many of you know, we're going to be overpopulating very quickly our morgue space. First and foremost, I hope all of you have an emergency management plan in place to get added space, whether it be refrigeration trucks or if it's another morgue location, whatever you have for that. The big thing is your funeral directors, because we aren't going to be having funerals, and sometimes because these patients are sitting for an extended period of time, funeral directors are not taking them as quickly. So you're going to plan on whatever your capacity is times 5. That is a safe plan to bet. It may be more than that depending on your location, but have storage space for that. Also, presently, I know everybody's protocol is you shroud that patient up, put it on a stretcher, put the decedent or cadaver on a stretcher and send them to the morgue. Highly recommend using 2 sets of shrouds, using 2 of your hospital shrouds for each patient for a couple of reasons. First and foremost, they're going to be with you an extended period of time. The single shrouds, they always end up tearing, and there's going to be a lot of liquid loss possibly. Secondly, they're going to be using that to move that patient. So consider doubling or even tripling your shrouds. Secondly, I would highly recommend using a disposable air transfer device or a disposable repositioning thing, something to wrap that patient in stronger than the shroud. It makes it significantly easier to move that cadaver through the process without putting your caregivers or the cadaver at risk. Lastly, consider your stretchers and your storage devices. If we're moving that patient out into a separate location, like a truck or what have you, you're most likely not going to be able to put the stretchers in there. Plus, you are going to be running significantly low on stretchers due to our census increasing. Your best option, again, is to have a transfer type device that you can then move them off the stretcher and onto the new surface, whether it be shelving units or into a external storage facility. With that, I want to thank everybody for listening. If you have any questions or need more information about any of the products we used and or any of the techniques, please don't hesitate to contact myself at ccraigmile@hotmail.com or 315-955-5422. And you can also find us at craigmilehs.com. Thank you very much for your time, and be safe.